Welcome to the session 8 of batch 17 of Master Trainer program. And today's topic of discussion is very important, very relevant because this is what we want to really learn in real sense when it comes to patient communication. And the topic of discussion today is handling aggressive patient party. I think that's one place where we find very difficult to understand how to go about handling that situation, especially when there is no formal training, there is no guidelines. Even if there are guidelines, but those guidelines actually practically do not work in reality, and we are all baffled with this situation because we don't know what we are going to actually face. So, if I may ask all of you, how many of you have actually personally managed something like the patient party became aggressive and you were the person who was handling this? If anybody has some experience, you can share. I think both Mitu and Maheshwari have some experience to share. Mitu, go ahead, please. Share your experience and then Maheshwari.
So, a lot of time when I was working with my earlier hospitals, like Artemis, Max, Medanta, so there has been a lot of times patient parties have become a lot aggressive, sometimes about the bill details, lab details are not coming, we are not breaking it up, reports are not on time, uh, pressure ulcers ho gaye hain, nurse nahi dekh rahi. There have been a lot of things like,
Mm.
and it was very difficult because it was not only empathy, it was more of sympathy which used to come up,
Mm.
because every time they come and say like, aap dekho, if it happens to you, how are you going to react? And
Mm.
definitely when you think it that way, then at one point of time there is a mistake which you've done.
Mm.
You in your heart that, but you have to defend it. That's your job.
I agree.
So that has been very difficult, and I have handled a lot of difficult situations wherein I knew a small baby has already expired on the MRI table,
Mm.
and almost 4 hours I was with the baby in the ICU, and I had to break this news.
Oh.
I was not able to do that, and that I think was the most difficult for me, which happened. And though we learned a lot from that, but that's
Mm.
where I have always held it a very difficult situation which I had to do that. A
Mm.
lot of fights, a lot of things, but
Mm.
yes, that's how it was.
So could you directly communicate with the person who was aggressive and calm them down?
Yes, so what we did, we tried explaining it to them.
Mm.
And yes, though we could never say that this was an error which has happened, which
Mm.
was something, because the baby came with epilepsy and there
Mm.
was nothing which could actually go that wrong.
Mm.
But then we tried convincing them, uh, we tried comforting, extra benefits, we'll arrange this, we'll arrange that. But at one point of time, it gets difficult. It gets very
Mm.
difficult. So
And everybody reacts differently, so you don't know how this person is going to react and then
there
how
was a
to.
lot of fights, patthar फेंके बहुत कुछ किया. There were a
Mm.
lot of things which happened over the year, and I had to save my staff also, those who were on duty. I had to save my doctor also. We never confronted them. We never took them in the front of them. So we three of us were handling the situation directly.
Mm.
And then we were like, okay, they said we're going to put a case and everything. But at
Mm.
one point of time, then when we tried convincing them, like, if you're doing all this is not going to help anyone out of us, neither
Mm.
you nor us. So
Mm.
let's understand that how we can improvise it, because फिर वही होता है ना, आप वही बोलते हो जो होना था वो हो गया. It's all
But
यहाँ नहीं.
when they say something like this, जो होना था वो हो गया, do they really accept that kind of a
At
logic? Because
one point of time, because वहां पे सिर्फ यही समझना पड़ा था कि थोड़ा सा वीकर कौन है जो
mm.
समझ पाएगा what we are trying to explain.
Mm. Mm.
Because these are human minds, कहीं पे भी किसी से भी एरर हो सकता है, ऐसा नहीं है कि नहीं होगा. तो no world is free of errors. Explaining them, and lot of empathy, like I had to hold the mother's hand, उनको बहुत समझाया, बहुत. It was like I had to feel their pain to tell them that this is something that's happened.
Mm.
And by next day they got convinced, and then we went to their place also during the whole cremation and everything. We were there, and that's where. But now again, I still have connect with them. They still talk.
Mm.
So that's where I think it turned up into another thing.
Managed the situation so well that they were kind of, they could see that you were making all efforts to, see how they can be not compensated, but how they can at least be comforted with the
Yeah, so at
situation.
that point, that was how we handled it.
Yeah, that's very nice. So I think that also includes in case if there's an error at our end, or there is some kind of injury to the patient. For example, pressure source where which they expect that shouldn't happen because the patient is under our care. But we
Yeah.
know in spite of all care, we still see patients, getting pressure sores because of so many reasons. It's not always the negligence, but there could be even medical condition which actually, has more possibility of having pressure sores. Yeah, yeah. Thank you so much for sharing that, Mitu. I think, but the way you talk about how you have handled it, that shows that you could manage the show, but it must have caused a lot of stress to you and
It
stress
was.
and
So the whole night I didn't go to my house. I
no.
was there in the hospital because I was myself into a shock. Like, how do I go and tell them? So, but then we thought, let's gather it. It just can't be left it like that. So that's how it worked.
But do you think any initial training or preparation or some idea how to go about handling would have helped you? Because I'm sure you did all that out of your common sense and your experience.
No, it
Or
was like it was
the-
a very strategic move. We thought we just can't say it like this because the parents will not accept it.
Mhm,
Then it was like in the ICU, we tried showing it to them. We
mhm,
talked to them that the baby is not doing that great. Understand the prognosis is not that good. We
mhm.
build up that with
Yeah.
them because what happened is baby came in emergency. Emergency means everyone was just trying to handle it. So the
Mhm,
communication at that point of time was missed, saying that this is critical, the prognosis is bad.
mhm,
Now, once they missed it, when the baby went to MRI and this sudden thing happened, and it was like, now what to do? So therein we tried explaining them. So we explained them for 20 minutes and something, and then we said like, it is not doing good. फिर
mhm.
3 hours के बाद we broke it out कि this has happened here.
Yeah, we usually buy time to, first of all, gather our
Yeah.
confidence and also help them, come to terms
And
with
then
the.
it was very important because areas like this, you'll get a lot group of people who will just come and just start that. So for
Mm.
us, it was 8 in the night.
Any violent situation you have
Yeah.
handled?
So there was one which I handled. That was my first job,
Mm,
and there also what happened. This was also very like the neuro patient. This was a
mm,
boy, very young boy, 23 years old. He was on the bike on this Manesar highway, ye toll wala highway on the Delhi.
mm,
He had an accident, and his this bone was supposed to be taken out.
mm,
And post the surgery, this boy went into the coma.
mm,
And there was so much of hue and cry. They were like hitting up the things. They said, "We'll beat the doctor. We'll do the." That point also, if I recapitulate, what happened is like only the sympathy and the empathy and sitting with the patient relatives helped
mm,
me at that point of time. Like it was like throughout wherever, whatever they needed. So I still remember, जाते वक्त उन्होंने बोला कि give us this bone also. He was a surd. And they said कि we'll take it to Harmandir Saab because we want every body part to go with him.
mm,
Our doctor was not, he was like, nahi, we can't. We arranged everything for them. And there also, what I remember, the whole violence suddenly turned
mm,
into, nahi, nahi, our son was driving fast, वहां पे brakes nahi the, उससे ऐसे हो गया. The
mm.
conversation changed.
Yeah,
But it
yeah.
was again,
That's only once they calm down, they kind of, get in touch with reality and they start realizing that it's not anybody's fault, but maybe our own, a person's carelessness or not realizing
and
that
the only
how.
thing was, it was not a time to get loud. It was not a time to ask about the bills.
Yeah,
I had a pressure also that there is a
mm,
huge bill I need to clear.
yeah, yeah.
So I was like, no, no, I'll not talk about that. But I never had to ask them after that. They eventually everyone clears it. But at
Mm.
the one level, the finance will
Yeah,
come and
but
say,
you
yeah,
can't
bill
push
pass
them
karo.
for that. Sometimes when you
Haan,
push for that, that also agitates them because they
that
feel that
also.
you are only, talking to us because your bill is pending. Once your bill is
Yes.
clear, you will not even talk to us.
So
I think these are
we
all
were
very
just like,
small but very, important sensibilities that we have to keep in mind when we are
yeah.
having such, sensitive situations and cases. Absolutely.
Oh, that was, thank you.
Thank you, Meetu. Thank you so much. Yes, Maheshwari, I think you also have some experience to share. Go ahead, please. Yeah.
Ma'am, I'm not a clinician, so I don't have this vast experience like with aggressive patients. Only regarding management, administrative parts, I had underwent many little issues. But
Mhm.
one thing I would like to share here is like one patient who had a credit bill and he had paid it, but the
Mhm.
bill was not cleared. I mean, we didn't receive the amount. I think it was a
Mhm.
card payment.
Mhm.
He paid around 20,000 or something, and we didn't receive the amount. The problem was with my staff because he didn't give the customer copy to the patient.
Mhm.
So okay, it's fine if we don't give them. We have to take that customer copy and see whether we have received it. So he hasn't taken the copy only. He said, "Okay, the payment is done. You can leave." The patient left, and finally we had some. Closing the bill final the next day when we are going to wrap up all the bills and send it to the bank, we had a shortage of 20,000. So according to our hospital protocol, the staff shouldn't call the patient directly and ask them, please check whether the
Mhm.
amount has been credited from your account. But that person was so scared that whether we will detect from his salary or what. So he directly called the patient and he asked the XCs to please check whether the amount has received because we didn't get the amount. Obviously, all patients will not accept no, ma'am, because we have cleared the bill and we have sent them. And he said, no, no, already my amount is deducted and you're like to want to make me the double payment or what. So he like shouted like anything.
Mhm.
So again, we have to bear the loss, and we didn't ask them for them to pay again because there is no even we are ready to show the proof, but the patient was not ready to come and uh, talk to us also. Ma'am. Like this, I have many little small issues with patients.
Yeah. Yeah. So I think these, especially clinical situations where there is some kind of harm to the patient or injury to the patient or loss of some, life, some complication. These are the situations where people, are more likely to become aggressive. More than the patient, I think it is patient's family who becomes aggressive and then they start arguing and fighting with us. So, do you all have some response system in your hospital? Dr. Pradeep, even if you wish to answer without having your camera on, you can share if you wish to speak on this issue. So, do you all have any kind of a response system in your setup where you know that if there's a risk of violence or aggressive reaction, this is what we are supposed to be doing? No, isn't it? It's all left to the person who is facing it, isn't it?
Ma'am, we have one at the
Uh-huh.
hospice because, like I was mentioning even last time, there have been when the
Mm-hmm.
death takes place and if people aren't prepared,
Mm-hmm.
we've had like violent, like I was mentioning last time about people trying to resuscitate and beating the staff or pushing them away from, letting the person pass away. So,
Mm-hmm.
as a result of these series of, I think there was a phase we had where this seemed to be happening a lot because we were getting very new patients who've never been to the hospice who were dying in like 24 to
Mm-hmm.
48 hours, and it's very less time for us to prepare or get them on board to accept the situation.
Yeah.
So the medical director had set in a protocol in place in terms of like from the security post a certain amount of evening hours, like we don't allow people. Then they created some visitor passes.
Mm-hmm.
Where only two people can go in at a time, and now there's a protocol for which nurse will be called. So before, when this happened, all of us got calls in the middle of the night, and this, I mean, none of us are there. So it was kind of a mess. So now there's a certain protocol in terms of who will handle it, who needs to be informed, who will show up, who's the backup person,
Yeah.
who's going to be there. But in terms of like specific things, no, I would say we're
Mm-hmm.
far from training people, maybe specifically about how to handle it. So it
Yeah.
still might be a failing plan.
So I think today's session will address two, three aspects of aggressive patient behavior. See, one is we'll get a deeper understanding of why do people become aggressive. That will give you a lot of realization that a lot of aggressive reactions can be prevented if we proactively, are able to identify this situation and then mitigate it, on at right point of time. You will be actually able to prevent aggressive reactions coming from anybody, from patient party or from any other person. And then, in case if you are in this situation, what is the way to handle it? How do you go about managing the situation? What communications you need to make with the patient? For example, we to share that it was just sympathy, empathy, being around, talking to them. That's what actually they want. And that's what we are scared to do because we are scared for our life. We fear that if we go close to them, maybe if they catch hold of us, they hit us. But then if you already have good rapport with them, if you have good understanding with them, they are less likely to be aggressive. But then we need to weigh the situation, where to go close, where not to go close, because we have also seen situations where doctors or nurses, they just went straight away to the patient party, hoping that they will accept the situation and they will not, react to it in an adverse manner, but they were caught and they were manhandled by the patient party. We do have examples of this kind also. So this session will help us develop deeper understanding of how do you really prevent it, because my focus is always on how can we prevent such situation. But of course, if it happens, then what should be the steps we should take and what should be our communication? Of course, drawing from this learning, you can design your own system, that in your own system, how you want to train your staff to prevent and also manage the situation. So the first question that I want to ask you is, what are the situations or patient conditions where there is a likelihood of aggressive reaction? Maybe one by yes, Dr. Pradeep, yeah.
Yes, sir. Ma'am, in the emergency, where we find the patient with unknown diagnosis and where diagnosis has to be made, and in the critical areas, all in the operation theaters, ICUs, nursery, and these are the places where these things are usually happen. And but the more agitation will occur when there is a very less probability of having these events. For example, someone is going for radiology, for lab investigation, or in the physiotherapy. So, but more likely it's in the critical area, ma'am.
All critical areas where, because the outcome is uncertain and emotions are high, and sometimes our behavior is not very responsible with them because we handle everything the way we handle every day. So we are also not very proactive or very sensitive in our handling in those situations. So there's all the more possibility. You're very right, in emergency, in outside labor room, outside OT, outside ICU, critical care areas, I think there's all possibility of aggressive reaction. I completely agree. So what medical conditions or the patient conditions you can expect aggressive reaction coming from either patient or patient's family?
Ma'am, basically, when the patient come and register their name in the filing, when they have to put a new file, or we had entered the patient's name, age properly, barcode was, everything was correct, but her name was wrong. We have the previous patient's name was printed in her file. So she was not sure whether her medication prescription was hers or the previous patient's.
Absolutely.
So she came with the prescription and she made a big issue and she was fighting with the person who gave her that file. I can't take this medication. Yesterday night I slept without my medicines. So you have to be answerable for my condition now. So she had a very big argument, and I was the person who addressed that, and it's very difficult for me to convince her, ma'am. She's not ready to accept.
Yeah. So see, even this something that appears very small issue to us, that it's okay. Of course, there's a mistake at our end, but if you have come to us, that's good that you have noticed it and you have come back to us, and then we are ready to rectify it. But then how people react, it's very difficult. So see, medical conditions like where the patient is in a traumatic brain injury or dementia or delirium, neurological disorders, in such situations, patient can act aggressive. So we know even in mental health conditions like schizophrenia, bipolar disorder, personality disorders. So there again, patient can get agitated, can act aggressive with us. People who are under the influence of drug or some substance abuse, alcohol, even they can, act aggressive. So at this point, I'm reminded of that case that happened in Kerala for that young doctor. I don't know how many of you remember that case. It was I think that was Vanita. That was her name, if I'm not mistaken. Yeah. So it was Dr. Vanita who was attending to this male patient in the middle of night all alone. So that means there has to be a triage, not just for the medical condition, but triage for also identifying situations where there's a risk of violence or aggressive reaction coming from either patient or patient party. Why could we not anticipate a person who is under the influence of alcohol can attack or misbehave with the doctor who is all alone and in the middle of night? If we could, identify this as a risk factor right in the beginning and could make sure that the doctor is not left alone with the patient, we could have actually saved that doctor's life. I was, discussing with my daughter, how do you identify, people that they can become aggressive or there can be extreme reaction coming from patient side. So she's practicing dentist in US. So she said we do disc analysis. Anybody knows about disc analysis? I'm sure Michelle must be knowing because she must be using it. But for all others, see, disc analysis is more like personality test. I mean, a very simple way if I explain it. So we get to know about patient's personality. Then I asked her, I said, how can you do disc analysis for any patient at the OPD? I mean, you can't make the patient sit and take the whole questionnaire and then, analyze the answer and then identify what kind of personality the person has. She said, no, we don't do any formal disc analysis, but the staff is trained to identify and categorize the patient depending upon the interaction they would have with the patient. Right at the first instance, when the patient comes to the registration counter or the first front desk staff. So when they interact with the patient and they make the patient fill up a couple of forms, they are constantly observing and noting down the patient's temperament and overall behavior. And in a coded language, they write on the case sheet at one of the corner of the case sheet that what kind of person he or she is. And then when the next person handles that patient, they would already be knowing that, okay, this person is a little more anxious or aggressive or little fussy, whatever in coded language they write. And then they are more careful in managing those patients. And they're able to prevent all those kinds of aggressive reactions or dissatisfaction that the patient might have. So patients with any history of substance abuse or under the influence of alcohol, they are more likely to become aggressive. Even when you are in any kind of pain, whether severe or chronic pain, we have seen people acting agitated when they are under severe pain. Even environmental conditions like too hot, too cold, noise around you, overcrowding, even these situations can, make people react aggressively. So, like we have learned medical triaging, we must learn social triaging. I don't know how many of you have heard of this term because this is a term I have coined, social triaging, where you identify people and situations where there's more likelihood of aggressive reactions coming from them. And, if we handle with care those situations, I think we can prevent a lot of aggressive reactions that come later. My next question to all of you is, what are the common reasons why do people become aggressive? Have you ever thought? Why do people become aggressive? Why do they act aggressive? Yeah, Michelle has written, death happens with less time to prepare dysfunctional families. Yes, absolutely, I agree. If there's a unexpected death or you didn't get time to prepare the patient party and you announce death, there will be, you know, extreme reaction, like people acting very aggressive. Absolutely. What else?
But aggression is when like they are not coming to the hospital anyway for a comfort. They are already in a pressure and a stress, and the pressure is emotional, financial, physical, everything.
Hmm.
Secondly, the uncertainty of the
Hmm.
prognosis. Third, the communication. They don't know they are going to get the patient back or no,
Hmm.
and
Hmm.
everyone is leaving their jobs, everything. So
Hmm.
that uncertainty is
Hmm.
one. I think when they don't get the answer, they get very aggressive. Like, why are you not answering it? And if I talk about myself, when I go for an OPD appointment, and if I have to wait for 30 minutes for the time what I have been given, I
Hmm.
also would get aggressive.
Absolutely. Absolutely.
So
Yeah. So there can be many reasons. Like Arshi has also mentioned, feeling of injustice and lack of sympathy. I think I completely agree with you, Arshia. Very often, whenever you feel that people have been unjust to me, there's a possibility of, people becoming aggressive. And Michelle has written attitude or reaction of thought. Yes, when people don't react properly, they are not respectful, they are not kind, they're not compassionate, they are not sensitive. It can, cause that feeling of being, disrespected or not heard or not attended properly. So there's all possibility of aggressive reactions, you know. So when I was preparing for this session, I came across a very beautiful, explanation why people become angry. And I want to share that with you because that's going to help us actually categorize what kind of patients can become, more aggressive than others. Dr. Pradeep has written, when expectations are not met. I absolutely agree. So that means when they have some expectation and those expectations have not been, attended or addressed, it could be even unexpected expectation, but that needs to be addressed. That needs to be fine tuned. And when that is not done, then definitely there is a possibility of, aggressive reaction coming from the patient party. So let me share this screen with you and show you uh, my presentation because that's going to be very interesting for all of us to understand why do people become, is this slide visible? Sorry, it's still loading. Is it visible?
Yes, ma'am.
Okay. Okay. So as I said that there are situations and places and patients where there is more likelihood of aggressive reaction. Places like Dr. Pradeep mentioned, outside ICU, labor room, OT, emergency, there's always a possibility of aggressive reaction. And patients, when they are under influence of drug or they are in pain, and there are certain medical conditions when there is all possibility of people acting aggressive, and like Michelle mentioned, the sudden announcement of death, there's all possibility of aggressive reaction coming from the patient party. So we should be able to identify these situations and know that there is more likelihood of aggressive reaction coming from patients or patient party. So we need to, like we have a box which says handle with care. Similarly, we have a patient party which should be labeled as handle with care. So as I was saying that if you try to understand why people, get angry, this explanation by Mark Gorkin, it's very interesting explanation that he gives that there are four phases of anger that start from I. So whenever one has a palpable sense of injustice or injury, we'll talk about each one of them in brief. And then whenever there's an invasion, sense of invasion, and there's intention, there's a possibility of aggressive reaction. So let's understand what exactly we mean by injustice, injury, invasion, and intention. So when we talk about injustice, whenever the patient or the attendant feel that they are victim of any injustice or unfairness or disloyalty, they are likely to act aggressive because there's a resentment and they just want to take it out. So if we look at a couple of studies which clearly says that patients do experience that they have not been given just treatment by us. So according to this study, at Sweden, complaints related to poor treatment accounted for almost 13% of the grievances, and then approximately 30% of all reported negative experience related to their reception. So there is a feeling that I have not been given a fair treatment. This is a study in Uttar Pradesh which says that almost 57 or 60% of the women reported some or the other form of mistreatment during childbirth. And we can't deny this fact. We know, especially in government hospitals, mothers literally suffer at our hands. We are very inhumane, very aggressive, very intolerant to their behavior, and we mistreat them, and we are very aggressive with the patient and also patient party. The second angry eye is injury. So whenever the patient or their family member feel that they have experienced harm at our hand, like for example, Meetu was mentioning about the pressure sores. So, they would automatically connect pressure sores with carelessness. So that means we have not looked after the patient. So therefore, the patient has experienced harm. And in any case, we know a lot of harm happens, at our hands in the hospital. We know about patient falls in the, bathroom, or also, from the bed, or medication error, or wrong side surgery, wrong organ removal, wrong kind of, treatment. So all that is the harm that has happened at our hands. Also, it is not just the physical harm that the patient party is upset about. It could also be the disrespect or being discarded or ignored by us. So it is the psychological injury or the psychological trauma that they experience at our hand. And also there is a sense of insult and humiliation along with it. So for example, we tie patient's hands saying that the patient needs to be restrained because the patient is acting agitated, but we tie in a very tight manner without caring for any kind of harm that could happen to the patient. So once they come and complain that there are marks on the patient's arm, we are just not taking any responsibility, and we say because your patient was acting very aggressive, so what could have we done? That's where we have done, we kind of restrain the patient. So all this lead to resentment in the patient, and there's a possibility that the patient or patient party can react aggressively to us. So according to WHO, in low and middle income countries, almost 18.4% of the patients actually experience adverse event because of the unsafe care they receive at our hand. And almost 30% of these events actually lead to patients' death. So you can well imagine the seriousness of the concern. And the patient party is concerned about the harm that we can do to the patient. It's very genuine and understandable. So in another systemic study, it revealed that almost every 10th patient in the hospital suffer with one or the other, harm from our end. In another study, to review the adverse event, both first and the second victim, they suffer from emotional, psychological, physical, financial, and livelihood consequences. So it's not just the patient party, even our own team members could experience, harm at our hand or injury at our hand. In another study in the UK, New Zealand, US, Australia, and UK, 6 types of mistreatments were identified. And the most common was failure to meet professional standards of care, specifically being neglected and abandoned by healthcare. So you can well imagine, and this is again about birthing time. So again highlighting that we are insensitive with the mother who is in labor pain, and we literally ill-treat and mistreat them, and we neglect and abandon. The third angry eye is invasion. When the patient's privacy, freedom, autonomy, boundary and personal space are perceived to be constricted, disrupted, or violated. We all know when patients are in hospital, I mean, we walk into the room like as though it's our right. I don't know how many of us really knock at the door before we enter the room. We just put the curtain away without any sign or without any prior indication that we are coming in. So you can well imagine how uncomfortable it must be for the patient party. A lot of time when patients are asked to urinate or defecate on bed using urinal or bedpan, it's a very uncomfortable feeling. It's a very uncomfortable feeling. And sometimes we start examining the patient, asking the patient to lift their shirt or maybe open their pant, and we want to, examine the lower abdominal area. And with other healthcare professionals standing, around the patient party, it is genuinely a very uncomfortable experience and feeling. So that's where patients feel that, their integrity is being threatened of. Although we might say that it's for the patient's benefit, but there are certain protocols that we need to respect when we are examining the patient or doing some procedure, or when we are making the patient, uncover their body. So we need to remember that it can be a very uncomfortable feeling for anybody. So when all these, three invasions, so let me see what study we have about it. So in another study, patients, during their psychiatric consultation, they reported that they felt stigmatized and discriminated because of the mental health condition that they were suffering with. And even when it came to, discussing their details, they felt lack of privacy and confidentiality during the consultation. And you will all agree with me, especially in a government setup, we know we will never have one patient and one attendant in the room. There are a lot of people, overhearing the conversation. How uncomfortable it can be when you talk to them about any of their mental or even physical health condition. So patients have reported that they feel lack of privacy and comfort, when they are. So it's more like invasion by people and we being insensitive to the fact. So whenever, the invasion, injury, and being exposed to injustice, they kind of, attack the patient. There is an emergency and energy and determination to do something about this situation. So that is where the person might act out. It could be reflexive or it could be a purposeful way to challenge the status quo. So usually nobody comes with the plan to become aggressive. Nobody comes with a plan to become aggressive. It is the incidents one after the other that happen and that add to their, being upset and agitated, disrespected, and being unheard, and then being asked to pay, and then we not releasing their body. I mean, all sorts of things really, really frustrate them, and there's a possibility of people breaking down and acting out in that situation. So let's take a situation and do a role play about it. So I'm just showing the situation to all of you first, and then we discuss who will play the role of the doctor and the other members. So this is a real life case. I think I may have shared with you earlier, or maybe not. So in a government hospital, young lady, she was schizophrenic and she was under treatment, psychiatric treatment, and she was receiving antipsychotic drugs. Even throughout the pregnancy, she continued with the medication. So she delivered a normal, healthy child with the help of her husband in the labor room. So the doctor and everybody was quite comfortable and familiar with the patient's husband and the patient. So after the delivery, the mother was shifted to the ward. Mother breastfed the baby and she went to sleep after taking her medicines. Then in the middle of the night, the patient's attendant observed that the baby was not responding. She called the nurse, who immediately called the doctor on duty. The baby actually had aspirated milk and tragically passed away. So they tried to resuscitate, but because they discovered the incident too late, so even after trying, they could not save the child. So the patient's husband, who was otherwise very well behaved, very cordial with everyone, upon learning of his baby's death, became extremely agitated and furious. And he began shouting and acting aggressively towards the hospital staff, blaming them for the tragedy, and was just uncontrollable. So I'm going to stop sharing the. Where is it? Oh. But I'm not able to locate the. Right? Oh, how come this has gone to the other? Yeah. So, suppose if you had to handle this situation, who would like to take this challenge of handling this situation? Or you have to speak to the patient's husband, or it could be family, maybe husband and mother-in-law. Who will try to handle? Somebody who has not done the role play earlier.
No, I can do it, but before that, I just want to ask this question. During a condition like this, milk aspiration, does resuscitation really work? Is it intramedical point of view?
No, see, it's only if you get to know, at the earliest, you try to kind of, normally when they put the child, upside down and they try to put hit at the back and they try to take it out. More than that, I think they try to maintain the airway and then whatever possible, they try to do it. There's a possibility of saving, not that absolutely it's not possible. But then because they got to know very late, child had already turned blue. So there wasn't anything that could have been done in that case. Yeah. So Akshay, you will handle this case?
Try to.
Okay, no problem. Wonderful. So who would be the patient party? Michelle, are you comfortable if I ask you to be the patient party? Okay. Dr. Pradeep, I think you are in your workplace, so maybe you will not be able to participate. Or can you unmute your device and please reply?
Okay, sorry. Yes, ma'am.
So will you
Actually,
be
I
able
have. I can try.
Okay. So what role would you like to play?
Mm,
So what I would suggest, Dr. Pradeep, you hold on for a minute. Let Michelle and me to be the patient's attendant.
yes,
But
ma'am.
after they have done it, I would like you to play the role, in place of Arshia. I want you to make an
Sure,
effort,
ma'am.
make an attempt to
Sure, ma'am.
explain to the patient party. Is that okay? Because
Yes, ma'am.
coming from you will kind of showcase that this is how you can handle a situation.
Sure, ma'am.
Okay?
I will try. I will try.
So we'll all switch off our videos and so Mitu, let's assume that there is no husband, but the mother and mother-in-law, or maybe sister and mother-in-law. It could be anything. So Arshia, you will have to have your camera on because you will be the one who will be leading the discussion. I will be switching off my video, but maybe 3 to 5 minutes are okay, Arshia. And anywhere you feel that you're finding it uncomfortable, you can always say that, sorry, I want to stop here. You're free to kind of stop. There's no problem. Yeah, because I know you are not from a medical this thing, so it's not easy to take that challenge. But I'm glad that you want to be in that shoe and see how difficult it is for anybody to play that. Okay. So I'm going to switch off. Do you need any more information, Meetu, Michelle, or Arshia? Do you require any information? No. So we assume that the patient is in the ward. The baby has passed away, and now you both have got to know that the child has actually passed away. So, and you are a relative. You could be sister and mother. Let it be sister and mother to the patient. Is that okay? Okay. Arshia, do you require any more information?
Just one more thing.
Sure.
how, I mean, from medical perspective, how long does it really take, when the baby aspirates milk and then the patient passes away? I mean, the patient can pass away. Is it an immediate occurrence or it takes time, or from medical perspective, how does it happen? I mean, I
So-
just want to understand that how much of a negligence what it was
Okay, good question.
yeah.
Arshia, I think that's a very good question. Dr. Pradeep, would you like to help on this? Dr. Pradeep? Dr. Pradeep, am I audible to you?
Yes, ma'am. Yes, ma'am. Yes,
Yeah.
ma'am.
So could you answer Arshiya's question from your understanding? Her question is that how much time normally the child takes actually before the child dies once the child has aspirated milk? In how much time do you think the child normally?
Ma'am, it's basically a brain hypoxia. It may set in 3 minutes.
3 minutes.
So
But
once
then-
the child is aspirated, so asphyxiated, that means the child must be having a hypoxia of more than 3 minutes, 3 to 5 minutes.
3 to 5 minutes. But child has completely stopped breathing. More than hypoxia, I think it's complete stopping of breathing and then no heart.
It's around three. Again, ma'am, brain hypoxia for 3 minutes can cause
Cause this.
this
Okay.
thing.
Okay. Arshia, so maybe
And
5-10 minutes.
also the position, Arshia, like because once the baby is breastfeeding, so the position of the nose and position
Yeah.
of that also that
That
gets
also,
mangled
yeah.
at one point of
Yeah.
time.
Yeah.
So that also would be an added factor there.
Yeah. So in this, we are assuming that she breastfed and then she went to sleep. So quite possible, right? You're right, Mitu. It could be that the child actually got, asphyxiated just because the breast must have pressed against the nostrils of the baby, and then mother did not realize, and she went off to sleep in the same posture, and maybe the baby had actually stopped bleeding at that moment. There's a possibility for this.
And usually in hospitals, when in such a case, the nurse has to observe regularly the baby and the mother, on first day on the first night when the baby is sleeping with the mother.
So
Does it
Ashwin,
really
it's not
happen?
like observing. It's practically not possible for every nurse to go to, because it's every now and then the mother is breastfeeding. But then the mother has to be trained how to feed the child and how to make sure
Training.
that the child's breathing is not disrupted because of the pressure covering of nostrils because of by the breast or even clothes sometimes. So that explanation she's supposed to be giving to the mother.
And also one thing, like because this would be a vulnerable patient because of the condition.
Yeah.
So there has to be a special caution over here. And secondly, doctors don't advise doing a breastfeed while you lay down.
Yeah.
Always
It's
you have to
always,
sit and do that.
yeah, correct. So that part also should have been explained to the mother, and also the family could have been also, kind of warned, cautioned that, because she's under the influence of drug medicine. So she may not be that conscious and alert to check the child is comfortable or okay. So attendants should make sure that they supervise the baby and the mother when the mother is breastfeeding. So it's not solely the staff's responsibility. It is collective responsibility of the mother, the attendant, and the nurse, and of course the overall hospital. But because the child died in the hospital, so naturally the anger is against the hospital. Yeah. So I'm switching off my video. Any more question, Arshia?
No, I think
It's a very good question.
take
you're
it
asking.
as a
Yeah.
I'll take it as it goes. I don't know how it is going to pan out. I
It's
mean,
all
yeah.
right. The whole idea is that when we get into somebody's shoes, we realize it's not that easy. So therefore, I think I'm glad that you are taking this challenge. Okay.
Um, yeah, hi. Would you like to talk about something? So, ma'am, just one question here. Are they going to come to me in a room, or is it just happening there in the place
So you
itself.
can assume that it is in the same place. They know that the baby has, is no more. And they actually have to start with acting very aggressive and shouting and blaming you. And then you handling them and trying to calm them down. Yeah.
Can we
Learn-
connect with someone? Yeah, how is this happened? Like the baby was fine. We saw the baby in the morning. How is it happening? Like I'm astonished, Michelle. Can we connect with someone over here? Can anyone listen to us?
Yes, yes. Me too. This is Shia. I am.
No, I understand. I want to understand how the baby could die so fast. It just can't. You've just told us like the baby's died. How is it possible?
I'm very sorry. It's a big loss, but
No, it is a big loss. Please
yes, this
understand.
is a very big loss. But I would like to explain, how the situation happens. The baby aspirated the milk and was not able to, and because of the aspiration, the breathing stopped for the baby. And
How can the baby aspirate? You're in a hospital. It's not
I
at home.
understand.
I have not seen. I am the mother of the. She's my daughter. I know. We've got kids. I have not seen any kid dying just because the mother was feeding the baby. I don't think so. I am not aligned with Michelle. You please
Yeah,
take
no.
time. I really don't understand why is it that.
Yeah, and
And
you know she's unwell, right? Like we
yeah.
know this is a high risk delivery. We've been here. We've been talking to the authorities. We've been talking to all the doctors, the nurses in the wards. No, I mean, how could you have left her alone?
And the
Come on.
medicines they were also
Yeah,
giving, they all know the medicines she was on.
correct.
How do you leave? I don't know. This is like, I
What are we
really,
going to tell her? I don't know how she's going to react to this. Does she even know about it? Have you told her?
So, Michelle, Neetu, this is, as I explained earlier, it's a natural phenomenon. It takes the child because when the mother was feeding,
So if
it
it
takes
is
the child
natural, are
hardly
you
3 to 5 minutes. Yeah, it
so
takes the
every
child
baby
just
should
two
die
minutes
natural?
when the
say,
aspiration
every
occurs.
baby should
And
die during the breastfeeding then if it's natural. Do you
Correct. I mean, that
I
means you knew
understand.
that this is a possibility, right?
no, I don't
Oh
know.
my
I'm
God, I don't know how we're going to
yeah.
tell her this is not okay. Like,
I,
is there
uh,
somebody else we can talk to? This is not okay. Like, we want
Can I
our
ask
my
something?
niece
Can I
back.
ask something here, Michelle? In the beginning of when the child was delivered and when the baby was given to the mother at that time, our nurse had trained her on what and what not to keep in mind when
She is not in a condition to be
breastfeeding the child.
trained. Understand?
Yeah,
I understand, yes.
She's on
And and,
antipsychotic.
and and our nurse was also visiting the
When
room
did the nurse
once
visit?
and
When did the
again,
nurse
yeah.
visit?
When I
and
was there, she was not there.
When
I
did the
don't
nurse
remember
visit?
seeing.
If she was feeding,
exactly.
did the nurse come and see if the baby is being fed and they
Yes.
have to take the baby?
Especially nighttime. I mean, come
I,
on, this is like
Yeah, so
talking.
this
Absolutely.
yeah, so Mr. Neetu, this is somewhere I understand there could have been more care from the nurse,
we've lost the
but usually
baby.
it's
Yeah.
not.
What are we
Yes,
going
but
to tell
what
her?
I
She spent
regularly do
9
is the
months.
nurse is, yes, I do understand. And in the cases like this, as we had also explained to you, the mother was on the medication and there has to be more care from we wanted
See,
you to be also
the
watching the
patient
patient.
and the baby was a responsibility of the hospital. We
Correct.
had got healthy baby, and it
Yes.
is a big loss to the family. I really don't. This was a precious delivery for us, the first baby of her,
Very
and
big loss for us as well. I mean,
no,
I
you
am
don't have any loss. No, no, no. I
No,
don't.
no, and this was a very difficult time for her. Both of them have, my Jijaji has been like suffering as well because he's been so careful and cautious. Imagine for him to be the one, he's like
I think
distraught. I don't know how we're going to tell her. Look at
Nine
this.
months, 9
Yeah.
months. She's kept the baby, and now there's no baby. In spite of her all the conditions she had, how can you just tell me like it's happened, it's natural? I don't understand that.
No, I think we should see the nurse. Who was the nurse in charge? I think this is not an opportunity for any more negligence. I think there should be some action
there
No,
be
taken against them.
I've called the people like they're coming outside. I let them do the halla gulla over here. Let them
Yeah.
do whatever.
Correct. All the
You
people in
just
our
let
family are going
them.
to be here soon.
Yeah.
see, I can completely understand your situation. Let me talk to the nurse as well, and let me get back to
Can
you
you
on
get
this.
us the baby
Yes,
back? Can you
We
get us the
will.
baby back talking to the
I
nurse?
No,
am
I
really
think
sorry.
we should bring the nurse here. Let's see what she has to say.
Give
I
me
mean,
give me
come
some
on.
time. Let me as I explained earlier as well. This aspiration is a very natural phenomenon. It happens, and and what happens to the baby also happens in just 5 minutes of what happens. And the nurse also came within 15 minutes when she realized that the baby had passed away, and she also triggered and alarmed everyone that this has happened. And we tried to give the care, we tried to resuscitate, but by that time it was too late. So,
See, we don't understand all these technical jargons. We are not into medical.
yeah,
We just know one thing, that we've lost the baby because there was a negligence from the hospital or from the nurse. We just know this thing and we've lost the baby.
Yeah, how are we going
I
to
am
tell
not
her?
aligned with whatever happened, 15 minutes, 5 minutes, not. If you know it's a natural phenomena, it can happen in
Correct.
5 minutes. You should have a time of 5 minutes to come and see the baby. And,
Correct.
and also the baby has to be kept in the cot, or the baby has to sleep with the mother.
Mother.
Can we understand that? And why all that has been broken over here?
And
the
one or two
normal,
times, if you give information, we're not going to be able to understand, right? Like, first of all,
I
she's got
understand. This
already
is
an
also
issue.
very unexpected. This is for us as well. Normally these cases are rare. This is also a very unexpected happening that happens.
Sorry.
It's okay.
Sorry, Arshia, to have put you in a tight position.
Yeah, it's difficult.
We are bad patients, patient relatives. Sorry.
So I want to ask Arshia, how is it to be there in that position?
No,
But
it's really difficult. It is because I think it's more difficult because one is not able to. There's a lot of sadness in the mind of the doctor as well to having lost a patient.
yeah.
And if suppose there was a negligence from the hospital side, this is also a lot of fear and anxiety on how the patients will react.
Yeah, yeah.
But of course, if it is something as we discussed, natural phenomenon, it could have occurred, then it's also
Mhm.
very difficult to explain to the patient who might not understand in technical terms exactly what happened. And the emotions are high to be able to explain and control the situation is
So Arshia, in this case, we, although we were not at fault, but they could still blame us for the fault. And we also felt that maybe we could have been more careful. We should have informed the mother. We should have put the nurse, or maybe the child should not have been with the baby. Child could have been in the nursery so that the child was looked after. So there was some failure on our part, no doubt about it. But then cases where there is no visible failure, for example, uh, pressure source. I mean, that's somewhere they feel that you are at fault. You have gone wrong. So we also defend ourselves to thin nail. And the problem is that's where even we become aggressive and we start arguing and fighting with them. For example, in road traffic accident case, usually you will not get time to really connect with the patient party, and by the time you realize the patient is dead. So there again, there is no rapport building, there is no communication, there is no updating, and suddenly when you announce that, they are blaming us for the death, and we also fight tooth and nail, and that's where the aggressive reaction comes from both these sides. That's the problem. So here you were still trying to be nice, kind, polite, compassionate, understanding, trying to calm them down. But then, I mean, in a lot of situations, even if you want to, I mean, even we react in a very aggressive manner, and that's where things go out of control. So maybe Dr. Pradeep, I will ask you to take that situation of disclosure of medical error, where I would want you to, but not in this case, maybe in the coming case. But would you like to demonstrate any other way of handling this situation? If you have 5 minutes, and maybe, okay, so we'll all switch off our
Okay,
videos
that's okay.
and let Meetu and Michelle be the patient's attendant and you be the doctor on duty.
Yes.
Let me see. I think this is the doctor.
I can also understand, but I don't know, doctor, what has happened to our patient. Doctor, can you tell us what went wrong?
Are you the doctor who's managing the patient? Do you
Good
know
evening
what
to
we're
both
talking
of
about?
you, Mithu and Michelle. Uh, Actually, I'm sorry for your loss. Basically, uh, uh, your this thing, child has aspirated milk.
No, we don't understand
What
this.
what
We
is
don't
this
understand.
aspiration?
I am just trying to understand how could we lose a healthy baby? The baby was
So
3.5 kgs. How is
it's
it possible?
you're absolutely right, and I'm concerned for that. But there are certain conditions and unavoidable circumstances where we can't help. And I'm not going into the technicality because
डॉक्टर साहब सारी
we have
टेक्नोलॉजी छोड़ो, आप ये बताओ कि मदर के पास कोई नर्स क्यों नहीं थी आपकी? आप ये बताइए मेरे को, जब आपको पता था कि माँ दवाई लेती है और उसको होश नहीं रहेगा बच्चे को देखने के लिए, आपने क्यों नहीं बच्चे के मदर के पास में एक नर्स को छोड़ा, या बच्चे को क्यों नहीं आपने नर्सरी में रखा? आपने क्यों मदर को बच्चे को दिया? आपकी बहुत बड़ी लापरवाही है और आप अपनी लापरवाही को दूसरों पे डालना चाह रहे हैं।
yes, yes, ma'am, you're absolutely right. But I think we haven't been told like that mother is suffering from all these
सबको
conditions.
पता था, आपको
There
दवाइयाँ
are some.
तो दिखाई थी हमने, आपको पर्चे दिखाए थे,
हाँ।
आपके सारे स्टाफ को पता था कि उसको वो दिमाग की बीमारी की दवाई ले रही है वो। अब आप कह रहे हैं आपको पता नहीं था, सब पता था आप लोगों को, आपने क्यों नहीं ध्यान दिया? बच्चे को देना ही नहीं चाहिए था माँ को, जब आपको पता है कि दवाई लेने के बाद उसको होश नहीं होगा। अब आज कह रहे हैं कि मदर को पता नहीं लगा।
नहीं,
आप
पर अगर आपने दवाई देके उनको बोल दिया दूध पीने के लिए, मेरे को तो यही
हाँ,
समझ नहीं आ रहा, ऐसे कैसे?
हाँ,
और कब एजुकेशन दिया था उनको
हाँ।
कि ऐसे करना है वैसे करना है करके?
किसी ने बताया नहीं, मुझे तो नहीं बताया, मैं तो पेशेंट के साथ ही थी, किसी ने भी नहीं बताया मुझे तो
और
कि
किसी ने कहा भी नहीं
Then
साथ रहना है। अगर
आप
आपकी नर्स नहीं थी,
हाँ,
डॉक्टर आपके पास नहीं था, आप हमें बोल देते, हम बैठ जाते उनके
हाँ,
पास।
वो अभी पूछ
you're
रहे कि
absolutely right.
बच्चा कहाँ पे है
You're
करके।
absolutely right. But we'll definitely investigate it. And I'm really sorry
अरे
for your
इन्वेस्टिगेट
loss.
क्या
क्या
जो
करेंगे?
इन्वेस्टिगेट डॉक्टर साहब, हम आपकी
सब
इन्वेस्टिगेशन
इन्वेस्टिगेट
का
कुछ
क्या
नहीं
करेंगे?
होएगा।
ऐसे तो नहीं हो जाएंगे उनसे कैसे? हाउ आर वी गोइंग टू टॉक टू हर? शी इज
क्या?
नॉट गोइंग टू बी एबल टू बेयर
आपकी
दिस।
पूरी पूरी
माय
गलती है,
गॉड।
मैं तो पुलिस केस फाइल करूंगी, एफआईआर लॉन्च करूंगी कि आपकी लापरवाही की वजह से बच्चे की डेथ हुई है।
नहीं, मैंने तो गांव में फोन कर दिया, आ रहे हैं लोग, इनकी पिटाई होगी, इनको तभी पता चलेगा।
योर डिवाइस इज ऑन म्यूट मोड। डॉक्टर प्रदीप, योर
we can
डिवाइस।
only say that we are really sorry for that.
इस
No,
सॉरी
no.
बोलने से क्या होगा डॉक्टर साहब? आप बताइए,
We
बच्चा
can only
वापस आ
say,
जाएगा।
I can only say that we are really sorry for.
नहीं, पर बच्चा वापस आ जाएगा
Uh,
आपको
we,
सॉरी बोलने से, ये क्या
we will
बात?
take action against.
प्रीशियस बेबी था उसका, पहला बच्चा है
No, no,
उसका।
we will take
एक्शन तो
action
सर
against
आपको
that
तब लेना
staff
था जब
nurse.
बच्चा था, अब
Definitely.
जाने के बाद क्या एक्शन
और
लेंगे?
क्या करेंगे? हमने क्या करना है? एक्शन लो नहीं लो, हमें क्या फर्क पड़ना है?
हम तो सबको ये बोलेंगे, यहाँ अपना बच्चा नहीं लाना चाहिए, यहाँ आगे बच्चा मर ही जाता है,
नहीं
छोड़ो।
होना चाहिए।
आई थिंक हमको किसी और से बात करना है, ये तो नहीं चलेगा।
हाँ, बिल्कुल बिल्कुल, नहीं नहीं, बुलाओ, मीडिया को फोन करो।
Ma'am,
हम्म।
these things usually don't happen here, but
अब कैसे बोल सकते हैं ऐसे? आपको पता भी है शी नीड्स हेल्प, शी नीड्स एक्स्ट्रा हेल्प।
क्या?
How could we leave her alone even for like 5 minutes if you know this is something that could have happened? Thank
1 लाख रुपया
God.
दे के हमने डिलीवरी कराया, बच्चे को यहाँ रखा, आपने क्या किया? पैसे छापने की मशीन है बस, समझ आ रहा है, कुछ नहीं, बच्चे को तो बस कर दिया। मैंने मीडिया में फोन कर दिया, अब मेरे को लगता नहीं हमें इनसे बात करनी चाहिए।
ठीक है, ओके, कैन आई रिक्वेस्ट एवरीवन टू कम इन? सॉरी डॉक्टर।
I was so concerned that he's in the hospital. Someone's going to hear that.
But I think he's on with this AirPods, so thankfully nobody can overhear our conversation. Otherwise, they will. I didn't want to give you a chance to speak. Why? Because I wanted to show how when people become aggressive, they just do not listen. So I knew you could have calmed us, you could have, handled it, but then I wanted to show that, when people are out of their senses, they just don't listen anything. No logic works with them.
Ma'am, here we have to find out from the beginning. When these before that, there is a concept of 3P:
Hmm.
place, person, and physician.
Hmm.
With whom, among those relatives with whom I am having a good rapport, whether I am having a good rapport with my patient or not, I have to choose from the beginning. I don't have to wait for these things to happen. So every condition or every interaction with my patient can turn up into this. It's just a death. Even the
You are
other things.
proactive in communication with your patient, Dr. Pradeep, then I don't think, even if something like this happens, people will blame you for the outcome. The problem
Sure,
we are facing is we are not making any proactive communication with the patient party. We are assuming everything is going well. It's like, machine that's running and the patient is coming in, delivering and going. Patient is coming in, getting admitted, getting treated and going. But where is that human touch? Where is that connection? Where is that communication with them? When we fail to do that, that is in case
then
if something goes wrong, that is where they become those four eyes I'm talking about. Whenever there's some injustice, some injury, some unfair treatment that they receive at our hand, that is when, and if everything happens suddenly and there's a loss, see, sometimes if it is injustice, they take it with a pinch of salt. If there's some injury, they take it with a pinch of salt. But if they lose life, then what more do they have to lose? Please remember, patient party will become agitated. Unfortunately, the patient has died because they have nothing more to lose. Till then, they are very nice, sweet, cooperative with you. But if the patient has died, they have nothing more to lose. That is where they become agitated and they even go out of control. So I think discussing about how does the crisis develop and at what stage, what intervention can we do, can give us an idea where to intervene and how to, de-escalate at whatever point you are with the patient party. And in case if things completely go out of hand, then how do we manage the situation? So let me share a short protocol about it. Again, as I said, these are more like guidelines. Nothing can be, written in, strict order, because you don't know what situation you are facing and what will work. So let me share the screen with you and take the
I
discussion.
had a question. Can I ask?
Sure. Yes, yes, please go ahead.
So, during when my baby was born, my daughter, so at that time she had jaundice.
Mhm.
And she was in the hospital only, and they had kept her in the incubator inside her room itself with that UV rays thing. And we had to watch, like, the attendants only had to watch the child in that incubator, in that UV ray equipment, because they said, and you have to put some black, as in,
Cover the
a
eyes.
black on the eyes, cover the eyes, because it is dangerous for the eyes. And they told us this should not go away, otherwise the child can be blinded and things like those. Now, in this case, they completely gave it that responsibility to the patient and the attendant to look after the, little baby for the whole night. No nurse came in. No. Is it also the right thing to do? I'm
No.
just asking.
See, engaging patient in patient care is a good idea.
Yeah.
Guiding educated them is a good idea because they should be able to participate in patient care. But ultimate responsibility lies with them. Legally, they are supposed to be in charge of patient care till the patient is in the hospital.
Yeah.
So,
Yeah.
I mean, it's
Yeah,
completely.
because in this case, it was like we could not sleep the whole night. I mean, me being the new mother, just a day before I delivered a baby, I was like, because I was so concerned that I wanted nobody else should sleep. So I was looking once and again. And, in this case, I felt that it was not a fair treatment to
Yeah,
patient and the
you were
attendant
already so
actually looking
exhausted
after
after
the baby.
delivery. You must have been so exhausted after delivery. So for you to stay away
Exactly.
with such
Yeah,
a,
exactly.
yeah, I think these kind of improvisations are done by people, fair or unfair. I think we all know. But then, as long as it doesn't harm, people normally forget about it after a while. But it's only if something happens, then they don't spare us. But of course, it's completely their responsibility to supervise the child's, stay in the hospital or nursery or in the incubator. They're supposed to be looking at. Thank you. Thank you for that question. Yeah. So let me share the screen with you and share the presentation. As I said, that I think this case gave us an idea. This is a real life case that I've shared with you, where actually the patient party, especially the husband, completely became insane. He started hitting people. And fortunately, this case was this. I think I mentioned this case in the last session. Am I right? Did I? Yeah. And this was narrated to me by the senior resident, Kaini. She said I was the only person with whom he was not arguing or fighting or hitting back because she had developed rapport and kind of familiarity with the. That's the benefit of being familiar with the patient part. Now coming to the stages of crisis development and where we can actually mitigate or intervene and how we can intervene and also how to identify this stage. This will help us to see where things can be actually controlled completely and where things can go completely out of hand and how should we be managing. So the first stage that I am talking about is 1 second. Let me, yeah. Yeah. So, see, I always say that it always storms before it rains. There are always red flags. There are signs. And if you are quick to pick those warning signs, I think you can prevent most of the aggressive reaction coming from the patient party. So, it would not happen all of a sudden. But are we alert? Are our nurses, doctors, staff, are they alert? Because a lot of time they can see the warning signs, but nobody, kind of cares to attend to it. So there's a callousness, there's a, diffusion of responsibility. Why should I care? That's not my job. Let the security people see, let the nurses see, let the doctors see. So nobody attends to the patient's behavior or patient family's behavior. And that is where, if we could identify, we could actually control the situation right then and there itself. So this is a state where there is an observable and unusual change or increase in behavior. So what kind of behavior change do you see initially when people, start becoming agitated? Can you think of some behaviors?
Body language changes.
Body language changes, absolutely. So what exactly happens to the body language?
Will become a more aggressive body language. They'll move their hands a lot, and you can see anger in their eyes.
Anger in their eyes, facial expression changes.
They'll
They're
be
more aggressive.
crying or shouting, screaming.
Shouting. Yes. What else? Yes, Dr. Pradeep, go ahead, please.
Passive communication.
Mhm. Passive communication or passive aggressive communication?
Passive aggressive. Passive aggressive, both. What we
Passive.
are saying, they are not listening, they are not reacting.
Yeah, or it could be actually aggressive communication. Now they
That
are
is,
coming out with their anger. They were tolerating till now, which was more like passive and passive aggressive. But when crisis starts, it's usually aggressive communication. That is where they start shouting in a loud voice. Their body language changes, tone of voice changes. What else?
They
What do
could be crying or getting like really upset. So
yeah, they
you're not
respond.
able to, like do anything. So there's uncontrollable crying. There's probably like falling on the person who has passed away.
So honestly, more than crying, I think they are aggressive in their approach. Crying is they feel helpless.
No, in the sense like very aggressive, like loud wailing and
Yeah,
like where
absolutely.
nothing you can say is going to
Yeah,
kind of calm that down.
yeah, yeah. So they start now acting out. They start becoming aggressive with people around them. What else? Neetu, Maheshwari, what do you say?
Ma'am, sometimes they could even rough up the staff
They
or
could
break things in the
push. They
facility.
could push it. But much before that happens, when they are now, about to act out,
Hmm.
happens quite late. Initially, you
The-
will just, yes, Dr. Pradeep, you wish to add something?
Yeah, ma'am, there used to be more complaints on everything.
Absolutely. So a lot of time they are coming up to people and trying to clarify and ask questions. And we normally get agitated with that behavior. When they come and start asking questions, rather than actually meeting and addressing them and are trying to understand. If you remember the last class, initial steps are, if you are able to understand that they are upset, they are unhappy, they are dissatisfied, they want something that they are not getting, can we try to see what can be done to calm them down? So you will see the first stage is all about where they are speaking in a louder tone. They will be pacing up and down. They'll try to talk to different people, even sometimes patients on the other bed or attendants on the other bed, or maybe somebody outside in the hospital, or their friend, or their doctor, or their relative. So you will see them, expressing their doubt and asking a lot of questions, and even they will go to the hospital staff asking for help. And that is probably the very early stage if you are able to identify this and address their concern. So next of some of these slides are exactly what we discussed in the last class. So I'm not going to devote any time on them. So that is when you make them sit and try and listen to them and ask them to tell what they want, what is bothering them. Then you try to understand what exactly is on their mind and how they are seeing the situation. And then you try to find out what solution are they looking for, and if you're able to provide that, most of the situations can be handled at that early stage. For example, if somebody comes talking about pressure sore, and you take a note of it, and then you say, I'm really sorry, I think we should have noticed it earlier, but don't worry, we will take due care. And then you call your nurses and you tell them that every 2 hourly or every 1 hourly, we are going to change patient's condition, put a pill on left, put a pill on right. Then make sure that you apply medication and you clean the area. And so they see you taking action, they're happy. A patient like Maheshri was talking about that case where the patient's medicine and the name was changed. I mean, there was a confusion about it. The patient felt that it's not my prescription. No, there is an error at our end. Her concern is very genuine. If I would handle it, proactively by admitting that yes, there is an error and I admit it, give me little time, let me find out what exactly has happened. I will make corrections and will do whatever best can be done. When you address their concern, listen to their concern, find a solution, most of them go back happy and satisfied. Now, for example, a MRI patient has come for MRI machine is not working, and this patient requires MRI, it's an urgent case. Next, I mean, surgery is pending, depending upon the MRI report. So there you will make all effort to see that the MRI is done, whether in the same hospital or in another institute, in another lab or investigation center, and you get it done and you resolve it. You see, the idea is when you resolve their problem, this behavior will go down. So the next couple of slides is all about what we have discussed in the previous class. So we'll not spend much time. So if you pay attention, make them sit, ask them. This is how where you identify yourself and you follow the process. When you say that I'm so and so, I'm resident doctor, I'll be happy to help you. Let me understand what your concern is and see what best can be done to help you. In case if you think their behavior is not appropriate, they are shouting, it is in the ICU. And if you say it's not fair to talk in the ICU, is it okay if we sit and talk at a separate place? That means you are segregating them from there. And then you try to, kind of empathize when you say, I can see you're very upset. And, let me see how I can help you. So this was just to show how you, communicate and you identify yourself, follow the process. So this is what we discussed in the last class, where you ask them what their concern is, you listen to them attentively, you observe their body language, and when you pay attention, half this suffering diffuses when you seem to be attending to them promptly and listening to them effectively. So all those listening skills that we have discussed in the previous classes have to be brought in here. This is a crisis situation. So you need to actually make sure that you build rapport and you listen attentively, you ask questions, and you try to restate what they have said so that you are able to exactly understand their concern. When they're sharing their concern, it's important to stay quiet and listen to them. Don't try to interrupt, don't try to correct, don't try to justify, don't try to shun away their concern. Even your body language should not indicate that you are not interested or you don't think it's a big issue. Otherwise, they will feel that we are not, genuinely listening with a desire to help them. Empathy, we have discussed a couple of times where you try to see how they are looking at the situation and how it is bothering them. So rather than judging them, we acknowledge their suffering and we try to normalize and generalize, where we say, yes, I understand your concern and it is very normal to feel like this. Apology, I think it plays a very big role. The moment you realize that there has been some lack of service, lack of care, lack of attention, lack of, prompt attention, it's always good to apologize because ultimately they have suffered inconvenience because of us, if not any harm. Even that's something, see, for example, the patient did not take medicine, like the case Maheshri was talking about. Patient said, I did not take the medicine. So that's good that she did not take the medicine because she realized that probably this medicine is not meant for me. So when you appreciate and you say, that's so good that you were alert and you did not take the medicine. Of course, I apologize for the inconvenience that you had to come all the way to clarify this. But I'm glad that you made an effort to come and do so that there is no actual harm that has happened. So you are apologizing and as well as appreciating. This we have discussed in the last class. So whenever there is an error at our end, I think we have to take responsibility and ask for apology because only then they will feel satisfied. Now, a lot of time when we ask for apology, but that does not look like apology, they are not going to like it. They know that we are just saying it for the sake of saying. So when you say, see, no harm has actually happened. These medicines are just antioxidants and vitamins, so nothing has happened. Don't worry, nothing has happened. Or it happens sometimes, there's a computer failure and sometimes the machine prints it wrong. We can't give these silly excuses and ask for apology. They will not take it. So at this moment, it is important to check what does the patient want. This is all we have discussed. So again, I'm not spending any time on this. I want to take you to stage 2. For example, when their concern has not been addressed, they are not satisfied, then what happens? So here you will try to find a solution. You will not care for the behavior, even if they are acting little agitated. You will not say, you can't behave like this. You've not got to be nice. Can't you behave properly? You are in a hospital. You can't shout like this. So you are not focusing on their behavior, but you are focusing on finding the solution so that you can handle it. Now, if that does not work, or if we have not been able to manage that effectively, the patient or the condition is going to move to stage 2, and that stage is called defensive stage. Now, what happens in this stage? Now, they are agitated. We have not heard them. We have not tried to solve them. They are very unhappy. That's where their actually emotions now will take over. They are feeling ignored. They are feeling unheard. They are feeling, being treated unfairly. So that's where their emotions are going to take over the situation and their logic and their rationality would actually start fading away. So you will see them responding more with emotionality, losing rationality, loud voice, aggressive body language, and they may start challenging you or the authority you are representing, and they may also become belligerent, where they may talk all irrelevant things, blaming you and your hospital for being careless. For example, the way I intervened, I said, you people are all careless and you don't care for, you are just here, like me too was saying, you just care for money, you are here to make money. So all those things they will start talking, which is not related to the situation, but then because now they are, upset and emotionally hijacked, so they will talk things that are causing them hurt, and they are going to, spit that out at you. So behavior would be almost, same or maybe more aggressive. So they will start speaking in loud voice. They will start arguing with people around, for example, with the security staff, with technician and nursing staff. Suppose if these people try to calm that person down, that don't worry, please be quiet, don't make noise like this, they will not listen. They'll start arguing with them. Clearly, there will be an expression of dissatisfaction and blame game will start. They will not even agree with you. They will not listen to you. They will not, even if you ask, for example, to pay, for example, you say them that, okay, we will do the test, you go and make the payment. They'll say, no, 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 you first do the test and I'll make the payment later. Or you ask them to clear the bill, they will not agree. So that's where now they are not thinking rationally, but they are reacting emotionally. So in stage 2, again, your response should be to not react, but take control of the situation with a problem solving approach. So at this moment, there's a risk that we can also become aggressive and we might retaliate or we might act it for that, but we have to be very calm and sensible and looking for solution so that you can still manage the situation. So at this stage, it is good to provide them guidance by asking them to calm down and express properly. So when you tell them, see, I want to help you, I want to see how we can, look after the patient. But for that, you need to calm down and express what your concern is, and let me think how I can help you and see what best can be done. So you are providing them guidance to behave properly, but you are not reacting aggressively to tell them, you can't behave like this. This is not the way to talk. Why can't you speak properly? You can't shout at people around. So that will not help. That's more like, reacting to them. Again, giving them direction, what all they can do. For example, if they're not happy with something, see, if you're not happy, there's a way that you can, write a complaint about whatever your experience is. You also have an opportunity to give feedback. If you want, you can give your feedback. Or if we have a person who can, we have normally grievance officer or public relation officer or patient care coordinator. These are the people who usually attend to these complaints. So they can be even directed to go and meet with that person so that they can be heard by somebody and solution can be arrived. At the same time, you have to be assertive where you set boundaries, what is acceptable and what is not acceptable. For example, if they start shouting in the ICU or in OT or in labor room, that's where you will have to kind of communicate very clearly. See, I understand you are very upset, so you are very disturbed, but this is not the place where you should be, shouting in this manner. So let's go out and sit and talk, or maybe you can go to the grievance officer and talk about it. But we can't allow you to shout in the ICU. There are other patients. And also, very clearly you can spell out what you can do. So whatever solution you think you are offering them and you think that should work for them. For example, now this MRI machine has broken. So the patient party is acting aggressive with you. And you say, see, I can make arrangements to send the patient to another center and get the MRI done. I understand it needs to be done urgently. I understand the patient's surgery is pending. I'm ready to see how it can be done at the earliest. But then you need to calm down and behave properly because it's a public place. There are other patients there. So you are spelling out what you can do and what you expect from them. At the same time, please remember you can be firm but not aggressive. The moment you will become aggressive, they will also become aggressive. So a couple of things at this point you need to keep in mind. The first thing is keep safe distance because now this person is emotionally hijacked. So the person is not able to think logically. At this moment, at least maintain a distance of 3 feet and don't stand just exactly opposite to the person, rather stand at an angle. Because a lot of time when you're standing very close to them, they feel that we are invading in their place. I mean, they can get, alarmed and they can act out. So preferably, have a table in between you and them. So when you make them sit down, don't sit like we sit in a counseling room where we have no table in between. So it's always a good idea to have a table in between you and the patient party. That would automatically create a distance of 3 feet. Also, I recommend that whenever you are handling such situations or when you are in a counseling room, have 2 doors policy. When I say 2-door policy, see, normally when we are sitting on this side of the table, the patient party is closer to the gate. In case if you want to get out of the room, you will have to cross them at any point. The moment you will try to get up and start going out, they're going to catch hold of you because they'll feel, oh, you're running away or you're trying to escape. Their aggression might take over and they might start hitting you. So it's always a good idea to have an exit for them and an exit for you at your back. So in case if you think that they might become aggressive because the situation is intense, there's possibility of, for example, if there are 3 or 4 of them and you're all alone. Although we normally advise don't attend to such situations alone, you should have people around you. But then there's a risk that they might start hitting you. So therefore, it is better if you have a safe exit at your back so that you can walk out of the room, giving some reason, maybe that let me call my senior, let me ask my staff what exactly happened, so that you can ensure your safety at that time. So it's very important to be aware of your body position. As I said, if you try to stand eye to eye or toe to toe, so it is not usually you who will be doing it. There's a possibility your security staff might do something like this. Because when you call them in, they feel they can handle the situation and they will try to stand close to the patient party and try to challenge them. They are going to be threatened with that act. They will feel that their personal space is invaded, and out of anxiety they may act out either with the security staff or with the person who is doing it. So at this point, do not argue, don't speak for the sake of answering. And there is no need to answer every statement because they'll be telling a lot of things which may not have much sense. It's more that they are just venting out their anger. So rather than, answering every questions, you can ignore some of the challenging questions and redirect their attention to the patient's welfare. So I think we need to tell them that whatever need to be done, that should be attended to. Because, for example, if MRI is pending, then you see, I understand that you are upset about the delay, but rather than now discussing this, let's try to see how we can make that happen if we are in it. Or, for example, if the patient family is upset about some, wrong drug that has been given, so you kind of tell them that let's first see what best can be done to minimize the damage of the medicine. So redirect their attention to the issue at hand and don't get into that power struggle of answering everything that they are saying. So at the same time, it's always a good idea to let them vent because they have pent up energy. They're unhappy, they're agitated, they're angry. So as long as they're verbally venting out, it's perfectly all right. And there's no need to kind of, again, react to every statement they are making. But if you think you can't allow this, for example, if they're doing it in ICU, in OT, in labor room, in emergency, there, of course, you will have to give them direction to, not do that, display that behavior in that patient care area. But then, as long as it is possible, it's all right to allow them to vent their emotion. At the same time, I think we need to offer them choices and consequences because we need to set some limits. We can't allow them to, keep talking something that is not making sense. So sometimes when they're too disruptive or too aggressive, then we need to clearly tell them what is acceptable and what is not acceptable. So when you are setting limits, offer choices and consequences to the acting individual so that they know that if they are, if you will not control your behavior, I'm sorry, I'll have to call security to make sure that things don't go out of control. But don't don't promise any consequences that you can't deliver. For example, if you say, if you don't behave properly, I'm going to call police and get you jailed. So you can't do something like this. So don't give those kind of, I'm going to throw your patient out. I'm not going to treat your patient if you behave like this. So don't, announce such kind of consequences that you cannot deliver. Very important aspect of your conversation with them is your non-verbal communication. Make sure that your non-verbal communication is non-threatening and it is neutral. Because when the person is actually aggressive or angry and emotionally disturbed, they are less likely to listen to your words and they are actually paying more attention to your non. So, in case if our non-verbals are communicating that you are irritated or you're aggressive or you're going to hit them back, there's a possibility that they might take a lead and might hit you. At the same time, certain expressions can aggravate the situation, like when you say, I don't care, that's not my problem, I can't do anything about it, that's not my responsibility. So when you say, when your body language communicates something like this, they are likely to get agitated and become aggressive with you. Please remember, in any situation, the only one person you can control is you. So please do not overreact to the situation. Remain calm, rational, and professional. I know it is easy said than done, but that's one of the good ways to mitigate the situation. Because the way you will respond, it will directly affect the behavior coming from the patient party. So wherever possible, use assertion, where you communicate what you want to say, but you are not using wrong way of communicating. Some actions that we take or do that can actually aggravate the situation. For example, people start shouting back, or they start banging doors, or they start throwing patients' file or calling security without any provocation. Please remember, if we are doing something like this, it would definitely aggravate the situation. Through and through, it's very important to keep a check on your feelings, how you're feeling. Because in case if you are very upset and you are not able to manage, it's better to ask for help, and somebody should, either be with you or take over the situation from you. The third stage is stage of acting out. So acting out is this stage when the person has completely lost, touch with reality, and the person is now gone out of control. So they can start throwing things, they may start damaging furniture and other items, they may even start hitting people around them, and usually they are not capable of reasoning at this point. So, now this person is just out of control. So at this moment, your response should be safety. Make sure that you and those around you are safe. Seek assistance, whatever protocol you have set in your hospital to handle this situation. Activate that emergency procedure and then ask for assistance, so that you can be, you are safe and your team is also safe. So at that moment, trying to control the patient, hold the patient, tie the patient. Patient means the person who is aggressive is not advisable. In any case, legally also we cannot do that, because then they can blame that we try to, harm them or hurt them. So we just have to ensure that we are safe. Now, now I'm talking about stage 4. When everything is over, you will see when emotions calm down, people usually want to, make amends. They regret their actions. They will even come and apologize. But then we know they want to kind of, say sorry for what they have done. Although it opens an opportunity for the positive change, reconnection, and resolving the issue, but I understand it's not easy to accept the apology. But then I've seen a lot of time, even if you are very unhappy about what happened, usually I've seen hospital authorities do not encourage filing FIR or calling police, because they know it's another hassle. It's a call that you will have to take individually, whether you want to register case or file a complaint. But usually I've seen people, they will just calm down and they will try to, sort out and let go of situation. Now, when whole thing has happened, it's important to document the incident. So I'm sure we all have an incident reporting format where we need to, name the people who acted aggressive and the hospital staff who attended the situation. what exactly was the background situation? Why did that happen? Why did that aggressive reaction came in? That needs to be mentioned. How you responded and the steps you took to mitigate the situation. What was the outcome? What did both parties agree to in case if both parties finally agreed? What exactly aggravated the situation? If there were some factors they were contributing as fuel to the fire, then you need to identify those situations and give suggestions to prevent or avoid those situations. So CAPA is a very good tool that will help you here. The corrective action and the preventive action that you recommend, so that such situations do not, get repeated. And then of course your contact details, so that in case if somebody wants to reach out to you, you can contact. After the situation is over, I think this is one step I repeatedly remind. Make sure that you sit and reflect. Sit back to self-check-in, discuss with colleagues, read material to update, and then attend programs to learn crisis management. Every time we sit and reflect, I think this is a learning to take, and we are better prepared for the next situation. Rather than blaming the patient party, focus on what could have I done to prevent this. Where all can I plug in to minimize such things? The carry home message that I want to give you all is that crisis moments don't happen all of a sudden. There are always warning signs, there are always red flags, and there's an opportunity to intervene before the crisis. So rather than facing that serious situation, if we train our staff to be more vigilant about these warning signs, I think most of the situations can be handled at much earlier stage and handled effectively. So this is in nutshell about the protocol of handling aggressive patient party. So what questions do you have about the topic?
Ma'am, can I?
Sure.
Ma'am, what will be your response in that role play when the unexpected thing has happened? Someone has lost his life, and they are blaming the hospital and the doctors.
So I think I would assume that I have already interacted with the patient party, and I would have, we have developed rapport. For example, I'm talking about that senior resident. I'm assuming that I'm that resident who was there in the labor room with the patient's husband when the mother delivered the baby. So in that case, I think calming that person down, making that person sit down, and letting that person vent, and admitting that yes, it's something very serious. Anybody in your place would be upset like this is justified. Although aggressive behavior is not justified. But then we do understand when something like this happens, people go in complete cognitive deficit. So from there, of course, we need to take responsibility of, yes, we could have saved the baby if these things were done. But incidentally, in this case, rather not saying that even you had an attendant who could have looked after, or somebody from your side should have been there, who was more alert and more active and more responsible. So never get into that blame game. But some questions that can help, see, you were there in the labor room with me. I'm sure you saw that I was fully, attending to your wife and looking after her, making all efforts to make sure that baby is fine, mother is fine. So I hope you have faith in our intentions. Of course, it's a very big loss for you, but we won't do it deliberately or carelessly. Unfortunately, this has happened, and maybe because the mother was under the effect of medicine. So usually after half an hour, 45 minutes after taking medicine, people feel sleepy and drowsy. So there's a possibility that she was drowsy, she was, after taking medicine, she was sleepy. I wish any one of us was there. But practically, you also know that it is not possible for the nurse to be present with every breastfeeding mother. Of course, no amount of
And suppose the patient attendant says, no, we want to litigate this man. We want to frame the nurse. We want to frame the doctor. Then whether we will confront that or we will become a bit facilitator to that.
Assume you are the patient's husband. I'm talking to you. So you have said that I want to litigate. See, I know you're very upset and you want to file a case. Of course, that's your right. I will not stop you. But at this moment, I also want to tell you that, you have lost your child. Your wife has lost her child. So it's very important to look after her welfare and your welfare. Litigating is not going to get us anything. Of course, you are free to file a case. I can't stop you from doing that. But more than that, I would say, let's see how we can look after your mother and your wife, and also how we can, look after you, because you also seem to be very upset about what. Of course, if you wish to file a case, I can't stop you, and I will not stop you. But usually these things don't get us anything. You will just be visiting, courts, and somebody from our hospital also will visit. But in the end, I don't think it gets anything for the patient. Let's see how we can look after your wife. That's more important. You can take this call even after a while, in case if you really want to do this. So, not telling that go and do it, I don't care, we haven't done anything wrong, we'll file the case to the nail in the court.
Thank you, ma'am.
Thank you. Any other question from the other participants? Michelle, go ahead, please.
Asher, you want to go first?
Sorry?
Just unmuted.
Yeah, you're
It's
unmuted.
okay. It's okay.
Now
Uh,
you're unmuted. No,
okay.
you need to unmute.
I think I'll go first. I think Michelle is saying that.
Okay, I didn't get that. Yes, Ashiya, go ahead.
So my question was that, I mean, in real situations, how many times is it does it really happen that the hospitals own up errors, medical errors, because
They don't.
that
They don't.
exactly.
But it's not just about owning up the mistake. It's helping them see what are they going to get out of the. So this is a real life case I've handled, where the lady delivered stillbirth, and then she went into amniotic fluid embolism. Family lost both mother and the child, and they were full on ready to go and damage the hospital and then call police and file. I just spoke to them and I said, I can understand it's something very abnormal situation. Anybody would lose their senses. But then what are you going to get out of it? They haven't done it deliberately. It's unfortunate that something like this happened to your patient. But then not everything is in our hands. So you have to be really very cautious, weigh your words, check your behavior. That's why I always say, if you already have good rapport with them, they will listen to you, they will trust you, they will understand that you haven't done anything, deliberately or careless. That confidence has to be won proactively. That helps in handling the situation. Yes, Michelle, I think you had a question.
Yeah.
Ashiya?
Ashay, yeah, so I had two questions, ma'am. One was about what happens to the person who lands up being on the other end, right? The staff person member. So, example, in this situation, the nurse who was alerted that the baby is not breathing, or the person who was part of that violent episode or the aggression, right? Like, so what steps is taken apart from incident reporting, which should take place at that point? Because obviously, one party is trying to like manage the patient, I mean, the caregivers or the angry set of relatives. But the person who was on kind of on the line of fire is also going through a lot of emotions, right? So, should there be something that is instituted
So,
prior?
yeah, people are talking about second victim now. People
Hmm.
are talking about that concept because anybody who is the caregiver also suffers with guilt and shame and all
Correct.
sorts of feelings. Yeah. So, but unfortunately, I mean, we are not very kind to the person, whatever
Yeah.
it is. We haven't seen people being very kind to them, and rather they kind of, I mean, consider them careless, irresponsible, and misbehaved, and sometimes they say you asked for it and you deserved it. I mean, these are the things people I've seen people saying. But I think we should have counseling services available for them. Somebody should talk to them. Somebody should listen to them. Somebody should make them feel, but then what is the learning? How are they going to make sure that this error does not get repeated? Because that way the focus should be on, sensitizing people, retraining people, skill building, so that they know their responsibility and they should be able to identify vulnerable patients. So in this case, if they were able to identify you, it's a high risk mother, it's a vulnerable case, so automatically your approach of care will be very different. Patient safety can be looked after if you are able to identify vulnerable patients. Pediatric cases, elderly patients, pregnant women, patients with mental health conditions, cognitive deficit patients. So we know visual handicap, speech issues, hearing issues, they're all invulnerable. If we know that these people have higher, handling need or care need, attention need, if we can look after, I think most of the errors can be prevented. But tell me honestly, how many of us really segregate and identify vulnerable? I don't know if anybody knows what vulnerable patient is in real sense. Okay, this is a vulnerable patient.
Yeah, so I mean, most of the time when these incidents take place, it kind of becomes like gossip, right? It spreads all over the healthcare setting like this wildfire. The person is embarrassed, insulted. There's a lot of blame that usually takes place. Some of them might land up even losing their jobs as a result of what has taken place, right? Disciplinary actions, basically.
Absolutely.
So
Yeah.
I don't know, does debriefing help at that point, and at or like at a later point, like for everybody? Because like you were saying, right, it's not like it'll not happen, maybe not with the same person, but it could happen with somebody else, right, in
Yes.
another department who is far removed from the situation. So that kind of brings me to my second question, whether does training have to be like very specific, in the sense like what you will train nurses and what you will train maybe the security?
Absolutely. There has
Yeah,
to be very
so
specific
in
agenda, specific training goals, and strategy. Absolutely.
yeah, because when I was just recollecting, we've had experiences where the nurse or the doctor in charge were extremely calm and trying to kind of like manage the situation, and then you have the security like yelling and screaming far away and like chasing people, pushing the mob and things like that, which kind of angered the
It
situation,
happened in
made
Delhi.
it
It was
worse.
AIDS trauma center. A big girl child was brought from a neighborhood area. She was playing on the rooftop. She fell all of a sudden, and she was brought to the hospital. There were a lot of people. I mean, all neighborhood also must have come in because naturally, if you get to know that somebody's daughter fell, so everybody went to the hospital. The security staff was very rude, very aggressive. He was not well behaved. So these people got real, and unfortunately, the girl died. These people just damage everything in the trauma center. So if you don't know how to behave, how to handle mob, how to react to, respond to such situations, then you're calling for a problem. There's no doubt about it.
Right. So it kind of becomes everybody's responsibility, right? Like if training has to happen because
Really.
we might notice it, but then informing people.
Absolutely.
Thank you.
Thank you for that question. So I'll just quickly post the feedback form and request everyone to share their feedback. Give me 1 second to copy
I
the.
have one more question.
Sure, please go ahead.
Ma'am, do you think, and I mean, it's for anyone who knows about it, does this system, of owning up, because I know that in US and in Europe, there are incident reporting and learning systems, where even there are websites and portals, government websites and portals where incident learning and reporting systems, are logged. Incidents are logged and they're analyzed, and near misses and all kind of incidents. Even in Japan, there is a system of even reporting near misses,
Mm.
which is very important. It didn't happen, but how could future incident be reported? Do you think
Yeah.
this practice is really prevalent abroad, or is it also on more on paper there, and it's not prevalent in India? I mean, is there a very big difference?
Yeah.
Or
Their patient body is very active. They're very, not only active, but they're very well informed. So patient participation is when I went 10 years ago for that program, patient experience officer, they were patient advocates and patient, you know. So what I'm saying, there the chances of hiding are very, very low, because the system is quite transparent. There are things, of course, things must be brushed under the carpet. A lot of, Netflix documentary, when I see, I get to notice, see, they are not completely clean. But of course, they are better than us in certain areas. We are still in infancy. We don't like to share our, an incident, because we think our reputation will go down. That's the biggest risk, and that will affect their performance and turnover and income. So they don't want to risk that. And we also know that media sometimes overplays certain uh, things if the hospital report. So I have asked a lot of hospitals to do some research work with me, where we do pre and post training assessment, where actually we get patient feedback, and nobody's open. They say, but nobody comes forward, because nobody wants to share their internal information. So that's it. That's it. Unless something like some mandatory, actions are asked by government, but there also is more of a paperwork. We all know. Hospital infection rate 0, patient
yeah.
safety incident 0, drug reaction 0, patient death 0.
I mean, I attended a session where I was told that even the AFIs are not reported, as in the adverse events following immunization are not reported by the officers. And even in government hospitals, there is a lot of resistance to.
In one of the programs, where the program was for nurses. So one of them shared her experience. She said, I will not name the hospital because that's not fair. She said something happened in the OT. So in the nurse's notes, I wrote that incident, that this is what happened. She said immediately the doctor came in, said, "Pado isko, remove this page. You can't report this. Take it out." She said, "I have nothing. Just took it out and tore and threw." So incident reporting to kahan se hoga? We are miles away from that. Miles away. मुझे नहीं लगता मेरे लाइफ टाइम में होगा ये. आप लोगों के लाइफ टाइम में होगा शायद.
See, I think it depends more on the leadership also, because what I have seen is, if your leaders are inclined towards, and if you have some rewards with the incident reporting. So for the near misses, we do reward the people whoever report the near miss. So we have a weekly wall of fame only for near misses, and the best near miss is awarded then. And that person who has actually reported that near miss is a part of that project now. And once we lead that project and we get some benefit out of it, there is a percentage share shared with that person. So, because it was we did a second victim survey also for us, wherein we have peer level support, we have counselors added with us wherever, and there were a lot of things where the supervisors were more into like report nahi karna hai. Like when we did a second victim survey, we got so much of insight saying that we want to report, we know it is happening, but then we say report karenge to mujhe kya farak padta hai. But then the farak was changed. And then we had counselors on our board. We did a lot of counseling with one of the emo needs agency. We connected with them, and now we've seen a change in people, reporting back, the trust. So that's where, and it's in infancy. No wonder.
Once
Yeah,
that
so we know
blame
that-
and shame goes away, then only it can happen. But just one point there, so near misses, I think, is not a very, because it's not a sentinel event. It's not something has already happened. Does near misses give, because it's not already happened, it was a near miss, it was saved. And it gives a lot of information. I mean, I'm just thinking if, a regular practice of reporting near misses can be much more beneficial. The other, other incidents cannot be reported. They had their fear. There's a lot of reputation.
So that is why they've taken a safe route, no?
Yeah,
You've
that's
already-
what I'm saying. I mean,
Uh,
and it's a
Because
good
there was no
practice.
one who was reporting. It was only when the customer would come and shout on us, we would know, Acha, ye ho gaya. So we couldn't get, the only thing we could get is add into their KRA, add into their PMS, and add it as a reward. So it's not seen as a bad thing if someone's done that.
So incentives are important.
Yeah, we definitely, for us, that only worked.
Good idea. Good. So I have shared the feedback form in the chat box. Those who have, I can see, 3 of you have done it, yeah. Just 2 of you are left, I think Neetu and Arshia. So next session we will have on coming Wednesday, that is 24th, no, 31st, I'm sorry. Who all are presenting on 31st? Michelle and I think 3 of you said you want to present. 3 people cannot present. So 2 will present in the next one and rest 2 will present in the last one. So
I
maybe
can do the next one. Yeah.
Arshia, you want to present when?
31st, next
So Arshia and Michelle will present on 31st and Meetu and Shikha will present in the last session.
So, ma'am,
Yes.
I have selected the storytelling wala, and Dr. Pradeep already took that last week. So, is it okay for me to do the same, or should I take another
Change, yeah.
take another topic?
Take another.
Okay.
It's better, no? Because then we will cover at least one more addition.
And so it has to be healthcare related only, right? Whatever topic, whatever presentation I give, it has to be related to what we are studying here, or it can be a.
You can discuss with me. I think once you share the details with me, I will be able to give you a better reply to that. Yeah.
Ma'am, I can share it over the weekend.
Mhm.
I
Okay.
started
Yeah, I mean, there should be little
want-
time for me to,
go through and
go through and discuss with you. Usually I immediately see and I connect back also. But then at times if I'm occupied, Saturday I'm expecting some guest at home, so whole day I will be occupied. So maybe Sunday then, or either or Friday.
sure. Let's
I think 4 of you have done. Who's left? I think Arshia, you are doing. Yeah. Go ahead, yeah. So 2 more sessions to go, and we are about to complete the program. So initial 2-3 sessions we are thinking, oh, we have just started. But once session 5 are over, it really speeds up, and then it's time to. Anything else you wish to ask or say? Anybody? Since our share is completing, so we can take 1 minute. So for the last session, please think of your feedback, because I will be requesting all of you to give your feedback. And then any changes that you suggest that you want to advise for the future programs. Keep it ready so that we can discuss in the next, in the last session. Yeah. So I think I've received a response from all 5 of you. I'll not hold you further. It's already 10:20. I close this session. So thank you so much. Good night.
Thank you. Thank you, ma'am. Good night, everybody.
Thanks, Ines. Thanks, Ines. Good night.